The topic for discussion is related to the recently conducted nephrology quiz for the final MDA residents in our institute. It was a total of 60 questions. They are related to nephro and the general or clinical topics. The aim of this exam is to make them orient towards the NEET SS and also the upcoming practical and theory exam they are having. So the questions were formulated as a hybrid one, not only MCQ, some direct question answer type of theme also kept because they might encounter direct viva question during their practical. So the answer discussion of that recently conducted one. And this is Best Brain in Nephrology Quiz, second edition 2025. See the answers, the question. First question, what type of stone it is composition? So this is the NCCT section. Here you can look at the stone, how big it is. Here is the liver. You can see how big the stone is. These kind of bigger stones are always white stones. Composition is magnesium phosphate. Most of the student wrote to white correct, but composition you made a mistake. So go through the composition also. Okay. What is the condition? This is the ultrasound image showing multiple cysts in the kidney. There are some bigger cysts, smaller cysts. Which name any one drug which recently approved for its use? Condition is ADPCKD. Any one drug, tolvaptan, not recently. Few years back it has been approved around 2015-17 times. Now more new drugs are upcoming, metformin also in the list. Whoever wrote tolvaptan, any other new drug, we give full mark. This question kept to make you sensitized to see the ultrasound images while interpreting the reports. And some student might be having doubt, why not it is ARPCKD? Yeah, only image is there, question is direct. So you have to select the most common one. Which is most common? ADPCKD is most common. Okay. The kidney size is bigger, way bigger. In ADPCKD, the kidney size will be way bigger. So the answer is ADPCKD, the drug is tolvaptan. What is the category of albuminuria? If not diabetic, what else it could be? As you know, albuminuria are of three category, A1, A2, A3. Less than 30 milligram is A1, 30 to 300 is A2, more than 300 is A3. So the category here is A2. Albumin creatinine is a ratio. Many a times the unit might be confusing, but as of now, remember 30 to 300 unit. Usually they will tally it for the albumin and the creatinine. What it represents, it is one of the short marker for the 24-hour urinary albumin, which is represented in milligram. So that is why I'm saying it as 72 milligram. The category is A2. If not diabetic, where else it can be common? Chronic glomerulonephritis, also a part of CKD. As a false positive condition, sometime in a significant UTI, mild rise can be there. So the other two conditions you can mention as chronic glomerulonephritis, CKD, any cause, hypertension, chronic glomerulonephritis, ADP, CKD, other autoimmune etiology, whatever it is, you can write. We give full mark. Pro-PKD score, direct question, the answer is ADP, CKD. Another spot where students get confused. What is this? It is getting the curve. Most of the time you will see the catheter direct. This simple hemodialysis catheter. Whereas this is taking a curve. So this is permacath. What is this curve? This is the site where the catheter is entering the vessel. This is the site where the catheter is exiting the skin. This area from here to here is under the skin. It is called a subcutaneous tunnel. subcutaneous tunnel. So it is also called as subcutaneous tunneled hemodialysis catheter, also called as permacath, on the right internal jugular vein, being used for hemodialysis. Regarding permacath, there are further videos in the channel. You can go through it if you want to know more about how it is made and all, what is the advantage, disadvantage and all. Another spotted type of question. Identify and mention the indication. It is degestant, double gestant, connecting the kidney pelvic calyceal system to the bladder. What is the indication? Any bladder outlet obstruction. Stones, ureter, any lesion, any obstruction in the ureter itself, pyelonephritis where urine is so thick it is not able to pass down. We need a firm structure like stent. Hydronephrosis, any etiology which is causing hydronephrosis. Whoever wrote any of this terminology, we give full mark. Bladder outlet obstruction, stone, pyelonephritis, malignancy, whatever you wrote, if the answer is towards bladder outlet obstruction, we give full mark. Correct question, sodium composition milliequivalent is 31. What could be the possible diagnosis and what is the most common cause in this age group? In the case, we have kept the entire case. Since it is in the YouTube, we have covered just eyes. We covered it. It was very clear. The case of nephrotic syndrome, full-blown swelling. In less than 20 years, the most common cause is podocytopathy. Why it is called podocytopathy? It is the pathology of the podocytes, under which minimal change disease, FSGS, comes. Out of which these two, which is more common, minimal change disease is more common. So nephrotic syndrome, even podocytopathy, if it is written is correct, MCD, if it is written correct. Those students who mentioned FSGS, yes, they gave the mark, but you know, MCD is more common than FSGS in this age group. Question related to the previous one only, 20-year-old with generalized edema. The clue is generalized edema. The report is having very high TSH. What it could be? What were the clues related to the previous patient? Generalized edema, thyroid binding, globulin loss in the urine, because in the nephrotic the patient will be losing a lot of protein, which include TIBG also, so TSH goes high. So this is the diagnosis. Another clue you might get while evaluating for nephrotic syndrome. So the diagnosis of nephrotic syndrome, and what is the explanation? Loss of thyroid binding globulin. To treat nephrotic, it will come to its normal state. Especially in acute situations of nephrotic where TSH is way too high, many times treating nephrotic itself will bring that DSH towards normal range. Separately, L-toxin might not be required. Again, related to the same patient, what is the best treatment to reduce proteinuria at this point? Many of the students wrote IV albumin. It is not the answer. The answer is immunosuppression. What is the best treatment to reduce edema in primary nephrotic? Treat the primary disease, whichever it is. So primary nephrotic cause minimal change disease, which responds to immunosuppression. So answer is immunosuppression. So whenever nephrotic patient losing proteinuria, you should know the sequence. See, the patient is losing protein in the urine. So inside the blood vessel, albumin is not there. So oncotic pressure is not there. So that is why there is edema. So you can't focus edema separately. You can't focus to build the albumin separately. You focus what is causing this. The patient is losing the protein in the urine. So reduce that. How to reduce? Give the immunosuppression. That will be reduced, and that is the best step to reduce proteinuria. So 10 questions have been done. In a particular video, we'll see 10 questions each over a period of 6 videos. We will see the answer. Because there was a video where I covered all the 60 answers together. Because of some technical error, I could not upload the video. Sound got deleted. So that is why 10 questions per video we will see. And subsequently, we'll upload further videos every day. Bye bye.